it's Barton Jennings here from Lung and Sleep. In this video, I'm going to demonstrate an interesting case of a patient who had lung cancer, and it posed some very interesting management decisions along the way, which I think is really useful from a learning point of view. So this was a 70-year-old man who actually fell off a ladder and went to the hospital and was found to have a fractured left wrist. As a part of the trauma series, a CT chest was performed, and we can see that there is quite severe underlying parenchymal lung disease with these cystic changes throughout both lungs with volume loss on the right. However, there is also the incidental finding of a lung nodule just here in the left upper lobe, measuring about 2.5 centimetres in maximal diameter. This has quite concerning features. It's slightly lobulated and also spiculated. If we look at the images carefully, we can see that there is an airway here leading towards the lesion in the apico-posterior segment of the left upper lobe. We can follow that back to the left upper lobe here. We can follow that once again to the lesion, and you can see that the airway goes into that lesion. This would suggest that the best way to biopsy this lesion would be with radial EBUS, where a percutaneous CT guided biopsy would be fraught with significant danger given the underlying parenchymal lung disease, and the risk of pneumothorax would be extremely high. Given the position of the nodule also, relatively central within the lung, would make percutaneous biopsy difficult. So I think radial EBUS is the way to go to biopsy this lesion. This patient had an episode of pneumonia in 2019 in January, so had a CT scan at that time. So it's always useful after the incidental finding of a lung nodule to review previous imaging. And here we can see, firstly, on the right side, apart from significant destruction of the lung here, there is a pleural effusion and areas of consolidation consistent with infection. You can see once again there's a pleural effusion here. He was treated for infection at that time and made a very good recovery, and the pleural effusion completely resolved. If we look at this area of the lung nodule though, it's very interesting because just here we can see a small nodule which measures 2 millimeters in diameter, but this is in the exact position where the current incidental nodule was found, now to measure 2.5 centimeters. This would indicate that this nodule has slowly grown over the previous 2.5 years, indicating that it's most likely a slow-growing lung cancer. The PET scan confirmed this nodule to be intensely FDG avid with no evidence of metastatic disease to the hilar mediastinal lymph nodes or any distant spread. So this was an isolated FDG avid nodule, highly suspicious for a lung cancer, but a tissue diagnosis is required to plan treatment. Radial EBUS was performed to obtain a tissue diagnosis. Due to the position of the lesion, there was no endobronchial lesion visible, so the radial probe was used to locate the lesion in the apico-posterior segment of the left upper lobe, as we saw the CT scan showing us the roadmap. This is a fluoroscopic image of the radial probe within the guide sheath going through the bronchoscope into the lesion. You cannot see the lesion on fluoroscopy. However, the ultrasound image confirmed that the ultrasound was within the nodule, meaning that accurate biopsy could be performed. This is the biopsy sample showing tumour cells with a small amount of cytoplasm. There is nuclear moulding and crush artifact with a few mitoses seen. The TTF1 immunostain was positive, suggesting that this was of lung origin, and here you can see that the synaptophysin and the CD56 staining was also positive, and this would be consistent with a small cell carcinoma. So this poses a difficult management decision now, because here we have a patient who has a biopsy-proven lung cancer. The histology shows that this is consistent with a small cell carcinoma. The treatment for small cell carcinoma is a combination of chemotherapy and radiation, and it's generally thought not to be curable. However, based on the imaging, we can see that this nodule was present 2.5 years ago when it was just a tiny 2mm nodule, and over that period of time has slowly increased in size and not metastasized. This is very unusual for a small cell cancer, and it's certainly acting more like a non-small cell cancer. So this was discussed in our lung multidisciplinary team meeting, and it was decided that this patient should be treated based on how the tumour was behaving rather than what the biopsy actually told us. Because it's always possible that the biopsy was a sampling error and just took a small area of tumour that might have features of small cell, but might in fact be a non-small cell, or very occasionally a small cell carcinoma may act more like a non-small cell carcinoma, and we felt that that was most appropriate to treat according to the tumour behaviour rather than what the biopsy showed us. The patient was in good performance status, had minimal other comorbidity, and so it was felt that treatment with curative intent should be undertaken. The best way to do this is either with surgical resection or with stereotactic ablative radiotherapy. Let's have a look at his lung function to determine if he's a surgical candidate, because the concern is with regards to the severity of his underlying cystic lung disease. The lung function test here shows that his lung function is very good, and this is consistent with his very good exercise tolerance, although it's surprising based on the CT appearance showing so much destruction in the lungs. Here is a section of the resected lung. It shows areas of normal lung with blood vessels and airways, and here is the solid pale coloured tumour measuring 21mm in diameter. Superiorly here you can see areas of lung bullae where there is essentially loss of lung tissue. If we look microscopically, we can see that here's the solid tumour up here, adjacent to normal lung with some alveolar tissue. If we look closer on higher powered under the microscope, we can see in fact that there are features here of adenocarcinoma. There are columnar tumour cells lining alveolar spaces with large abnormal nuclei, but a moderate amount of cytoplasm. The tumour cells stained positive for TTF1, which is suggestive of an adenocarcinoma of lung origin. The CD56 was focally positive, but the synaptophysin stain was negative. There are occasional clusters of tumour cells seen which were degenerate and appeared to have a high nucleus to cytoplasmic ratio, which may look like a small cell carcinoma and may be why the biopsy showed features more consistent with small cell carcinoma. However, on the resected specimen, the majority of the tumour was clearly morphologically and also immunohistochemically consistent with an adenocarcinoma. And this certainly is more consistent with what our clinical suspicion was prior to obtaining the biopsy. Importantly, the tumour was completely excised, all lymph nodes were negative, so this was pathologically staged as a T1N0 fully resected adenocarcinoma of the lung. So this surgical procedure is expected to be curative and certainly offers the best chance of cure for the patient. And the case, I think, illustrates a couple of really important points. Firstly, the decision as to whether a patient is surgically operable should be made based on how well his exercise tolerance is and performance status is, as well as lung function testing, rather than the appearance of the lungs on the CT. And in this case, certainly the appearance of the lungs did not look good, and it looked as if there was severe underlying lung disease. However, based on a good exercise tolerance and very good lung function, it was certainly appropriate to proceed to a surgical resection. The other important point was that the tumour was treated based on the behaviour of the tumour rather than the actual histology from a small biopsy. And this turned out to be the right thing to do, because once the whole tumour was analysed histologically, it was confirmed that in fact it was predominantly adenocarcinoma, and the best treatment for a solitary early stage adenocarcinoma of the lung is certainly surgical resection. So hopefully this will achieve a cure for this patient, which is an excellent outcome, and I hope you have been able to enjoy this video and learned a few things along the way out of this fascinating case. Okay, see you later. Based on his good lung function and good performance status, it was decided that surgical resection of the lesion was most appropriate.